Dear EU members, I am Maurizio Colecchia. I am chair of the European Society of Uropathology, and it's my pleasure to share with my co-chair, Professor Ropre, this UROwebinar regarding this important issue, the bladder neoplasm. Will a morphological classification become obsolete? We have today experts about both the sides of the problem. Pathologists that are speaking about the news coming from the research, and the oncologists for the point of view regarding the clinical significance of molecular classification. And all of you in the audience can ask questions and writing them, and we have a 5 minutes Q&A session after every presentation. It is now my pleasure to present Dottoressa Alessia Cimadamore from Ancona University, and his title is Current Morphological Classification of the Bladder Neoplasms. Thanks, Alessia.
Good afternoon, everyone. Thank you for joining this webinar, and thank you to the chairman for the kind invitation. We are going to talk about the current morphological classification of the bladder neoplasm that is based on the WHO 4th edition. So we're going to focus on the non-invasive and invasive urothelial carcinoma, and I will introduce you the novelties of the WHO 5th edition. So we will focus on the morphological classification, which includes not only urothelial tumors, but also squamous cell carcinoma, glandular neoplasm with the adenocarcinoma, more rare entities like urachal neoplasm, tumor of Mullerian type, and neuroendocrine neoplasm. We are going to focus on urothelial tumors. In this section of the patient, of the radical cystectomy of the patient, we can see that there is the invasive component in the upper part and the non-invasive component in the lower part. The non-invasive component can show a flat appearance or exophytic or endophytic pattern of growth. So the non-invasive component, so the non-invasive neoplasm of the urothelium, have been classified according to the pattern of growth, so flat or papillary or inverted, and according to the grade. So there is a spectrum that goes from very indolent lesion to high-grade lesion, indolent lesion that just requires surveillance, to high-grade lesion that requires therapy. So we have the urothelium proliferation of uncertain malignant potential, called also urothelial hyperplasia. Then we have the urothelial dysplasia and the carcinoma in situ. On the other hand, we have papillary urothelial neoplasm of low malignant potential, LUMP, low-grade papillary carcinoma, and high-grade papillary carcinoma. So let's start with the flat lesion. We have the urothelial hyperplasia, in which I, as pathologist, I see a thickened urothelium, more benign cell layers with minimal or no cytological atypia, no true papillary fronts, and I can see this as de novo, isolated, and we don't know the clinical relevance of this lesion, but most of the time I can see this in a patient with a history or carcinoma or adjacent to a low-grade papillary lesion. And this is supported by the molecular data that we have on this lesion, in particular the presence of deletion of the chromosome 9 and alteration of the FGFR3, so the fibroblast growth factor receptor, that is common in the luminal subtypes and in the papillary lesions. Then we have the urothelial dysplasia, which by definition is characterized by cytological and architectural features that are believed to be preneoplastic, but fall short for the diagnosis of carcinoma in situ. So I can see there is something that is happening in that urothelium, some cells with nuclear enlargement, some disarray, some loss of polarity, but it's not enough to call it carcinoma in situ. And this is a controversial entity due to pure inter-cell reproducibility. Then we have the carcinoma in situ with a clear characteristic of malignant lesions, so nuclear enlargement, evident nucleoli, loss of polarity and discohesion. And this is predominantly a cytological diagnosis, because we should keep in mind that for a diagnosis of carcinoma in situ, this diagnosis does not require full thickness involvement of the urothelium. Then we have the spectrum of the papillary urothelial neoplasm that, according to the 2004-2016 grading system, is divided in three entities: the fun lump, low-grade papillary, and high-grade papillary. According to the WHO, we should grade this lesion according to the architecture and the cytological grade. So we should, at a low power magnification, if we see a disorder with an evident cytological atypia, we should call it high grade. Otherwise, if we see a low power order in architecture and a high power, we don't see evident cytological alteration, we should call it fun lump. Otherwise, we should call it low-grade papillary carcinoma. And it's important to distinguish these entities because each one of them are associated with a different recurrence rate and stage progression rate. But the issues with this grading system is related to the pure reproducibility and the pure inter-observer repeatability. Also, about 1/3 of the papillary lesions are characterized by heterogeneity in grade, so we can have low-grade and high-grade component in the same lesion. And the 5th edition clarifies how to call this lesion with minimal high-grade component. Then we have the invasive urothelial carcinoma, which most of them are conventional urothelial carcinoma. Up to 30% can show a divergent differentiation or also a subtype. The divergent differentiation, the most common is the squamous differentiation that you should keep in mind, because in the next presentation you will see a correlation with the molecular features. And of the what we call variant histologies, now we should call it subtypes, you should remember the micropapillary, the nesotype, the plasmacytoid, and the sarcomatoid. This is because they have prognostic and therapeutic implication. Also, all the divergent and histological subtypes are considered high-grade tumors, and as a pathologist, we should report the percentage of divergent differentiation variant morphology present in that third specimen or radical cystectomy specimen. And also, for, as I said, for some of these entities, a molecular equivalent exists. So you should remember the nesotype because it's characterized by this bland cytology that can be easily mistaken for a benign entities like convolutional hyperplasia or papillary non-invasive with inverted growth pattern. But then we should remember the plasmacytoid, the micropapillary, the sarcomatoid, because they are aggressive. So sometimes they present at higher stage with lymphovascular invasion and lymph node involvement, even at lower stage. In particular, the micropapillary is characterized by very aggressive subtypes, and also even in the T1 stage, some urologists consider the upfront radical cystectomy instead of local therapies. Then we should remember the squamous differentiation because it's related to therapeutic implication, in particular the basal squamous subtypes, as we see right after my presentation, is associated with benefit from the neoadjuvant chemotherapy. And in the end, the neuroendocrine differentiation that is associated with different management, therapeutic management, therapeutic chemotherapy. Then the WHO recognized the prognostic value of the extent of the laminar propria invasion. So recommend to report the extent of laminar propria invasion in T1 stage tumors in the third specimen, but do not specify which method we should use to report the extent of laminar propria invasion. So we can use either an histoanatomic method based on the lamina propria, or we can use the micrometric techniques. So we can say as pathologists, there is the microscopic invasion or an extensive invasion. But there is no head-to-head comparison between these two methods. So we can use one or another. Then in the 5th WHO classification, the histological characteristic will remain the gold standard. So there is an integration with the molecular features, but will still remain on the histological characteristic to perform our diagnosis. There is an updated nomenclature of the subtype histologies, and the term variant histology has been replaced with subtype because variant is reserved for genomic rather than morphological alteration. And then in this fifth edition, the WHO specified that for tumor with less than 5% of high-grade component, we should call it low-grade tumor with less than 5% of high-grade component. And because most of the time this tumor with a very low percentage of high-grade component behave like low-grade tumors. So we started from morphological classification in 1973. Then we redefined this morphological classification in 2004-2016. This classification has been oversimplified in two categories, the non-muscle invasive and the muscle invasive. We all know that inside the non-muscle invasive category are some T1 tumors with microscopic invasion of the lamina propria or extensive invasion, and also some subtypes that are very aggressive, like the necropapillary. So for each type of non-muscle invasive tumor, there are different considerations to keep in mind. And also in the muscle invasive category, we should offer different options, therapeutic options, also considering the subtypes and the molecular information. In fact, with the new data that come from the molecular data set and the molecular classification, we should be able to offer the appropriate therapy to each patient. Also because we have more than one option. We have neoadjuvant chemotherapy, neoadjuvant immunotherapy, target therapy in the metastatic phase. So we should move forward and integrate the morphological classification with the molecular data and the therapeutic option to propose an integrated classification. Thank you.
Thank you, Alessia. Nice presentation. There is one question at this moment from the audience. I read do patients with papillary urothelial neoplasm of low malignant potential need follow-up, or can they be discharged?
So as you have seen from the recurrence rate and the stage progression rate, the pan-LAMP or papillary neoplasm of low malignant potential are characterized by relatively high rate of recurrence, but they do not progress. So you should check on the patient, but it's not an aggressive lesion. So it never progresses into an invasive lesion. Sometimes can progress to low grade, but most of the time just recur. So it just should keep under surveillance.
Thank you. Then if there are other questions, we have sometimes at the end of all the presentations. And now I would introduce an expert of bladder neoplasm, such as Dr. Antonio Lopez Beltran from Champollion Clinical Center. And the intriguing theme is the molecular classification of bladder neoplasm.
So, hello everybody. I would like to thank the European School of Urology, the ISAP, and the ASU, and at the personal level, the organizer for having me here today to share my interest with you, all of you, in bladder pathology. And I also welcome all the attendees for the great choice they did this day in try to get some more information on what is going on in bladder pathology at this moment. So my presentation, these are my disclosures, and my presentation is related to the molecular classification of bladder neoplasms. We will discuss, we'll start with a background as usual, then we will discuss on the molecular taxonomy or classification, where are we at this moment, we will briefly discuss the potential for implementation in clinical practice, and we will end with some messages that you can discuss with your colleagues at home or with us by email. So this is bladder cancer. This is what we know and what we practice every day, urologists, pathologists, oncologists. So we have two basic diseases. We have non-muscle bladder cancer, which is the most common, naturally. Then we have the muscle-invasive bladder cancer, less common. When we see from the clinical aspects, what we notice is that from non-invasive to heavily invasive diseases, what we see is how the tumors can recur, can progress, or can be a matter of mortality. So in a molecular point of view, what we have learned classically is that when we analyze for instance, the status of the chromosomes in this disease, what we see is that there are main differences begin to see relevant when the tumor start to invade. That is very early. The T1, as you see in the panel on top of this presentation, of this slide. If you see in the panel below, you notice that common molecular genes, common alterations seen in bladder cancer, you see that it are also varied according to a stage, according to the pathological classification of the disease. And then to the right, what we see is the classic two pathways molecular classification of bladder cancer, which, as you see here, this is an accumulation of alterations, mutations that to drive the process into the more aggressive disease. Then this is the classic knowledge, but at some point, it appears this paper, this publication, which is seminal and very important for us and for our discussion today. So as you see here, this is the report on the so-called the Cancer Genome Atlas data. And as you see, it was based on 131 muscle invasive bladder cancer. And they identified that a high number of mutations characterize these tumors, which is important, as you all know, for immunocheckpoint inhibitors therapy. And then the type of pathways altered, we have seen that it was mainly cell cycle alterations, chromosome regulations, and other pathways, some of them related to current therapies, which is very important. But what is the most relevant part of this paper, is because they started to use a terminology similar to what is happening in the breast, because they identify molecular alterations that are typical from luminal type tumors or typical from basal type tumors. As you see here, luminal tumors, they identify two clusters, one very well differentiated tumor characterized at molecular level by alterations, by frequent alterations at the fibrillary growth factor receptor 3 gene, and the cluster 2 less differentiated tumors, and with alterations of the B53 gene. The basal tumors included the cluster 3, which were classically seen as a squamous cell carcinoma or a squamous differentiation. And they included also a cluster 4, which were characterized by epithelial mesenchymal transition genes alterations and heavy immune cell infiltration. So after that, there came a number of classifications from different institutions across the world. And I just will notice this one, which is by Robertson. It is, to me, this is a great paper. It's a paper that I recommend all of you to read. And as you see here, they classified muscle invasive bladder cancer in 3 luminal subtypes, basal squamous, and they incorporated the so-called neuronal to include those small cell, neuroendocrine tumors, and other submolecular subtypes related to this, but not previously known as in terms of morphology. Very interesting. So, and more recently, it came this molecular classification, which is received the name as a consensus molecular classification. It really appeared in 2019, but it was published in 2020 in European Urology. And again, it incorporates these 3 subtypes of the luminal. Again, the subtype of basal squamous, the neuronal, and they present a new category, which is a very poorly understood category with this name of stroma rich. As you see here, in the basal squamous carcinoma subtype, they have alterations of the epidermal growth factor receptor, which is important as a target for therapy. And luminal tumors, the luminal papillae are typically enriched in fibrillary growth factor receptor 3 alterations, including mutations. And the other 2 categories, they are not so related to this classic alteration in these urothelial carcinomas. So more PARC alterations and other cell cycles. So what is coming to the reality using this classification is that we can get certain information of the potential therapy related to these categories. That is very important to us. So if you believe that this is over, you are probably wrong. So this is a molecular classification or taxonomy or subtypes of bladder cancer is a process. It's an evolving process. And as you see here, in 2020, the Robertson provide a molecular classification for T1 tumors, which is very interesting, but we will not have time to talk about that today. And we, for instance, recently have reported a modification or refinement of this molecular classification, identifying 3 subtypes, very interesting. So at this point, if we believe that molecular classification of bladder cancer is important, then next question is, how could we implement this in our practice? So for us as pathologists, we believe that immunohistochemistry can help. As you see here, there are 2 publications. The one from the left is a meta-analysis that I recommended to you for you to read. It's very interesting paper. And in the right one, there you see that we have immunohistochemical markers to define the different categories. In particular, those big groups, luminal and basal. As you see here, if we use GATA3, CK20, uroplakin, then we can use this in practice, in reality, to add to our reports, to our pathology reports, to enrich the knowledge to the urologists and the oncologists. So this is the paper by Choi, in which these authors really put the basis for this potential utility of immunohistochemistry in the molecular classification. As you see here, they use CK56 to identify basal tumors, and they use CK20 to identify luminal tumors. And as you see, also, there are a good relationship with the Kaplan and Meier scores, with the survival advances, and even with the response to chemotherapy. We have validated this system in non-muscle invasive bladder cancer, as you see here. And at the molecular level, in this paper, we found a good correlation between immunohistochemistry and the molecular information provided by RT-PCR. Again, we have seen that the potentials, the clinical implication of this molecular refinement is similar to the one provided by pathological analysis, even at the survival level. The same, again, can be seen in muscle invasive bladder cancer. We have provided some data too on these molecular subtypes using immunochemistry with good correlations with molecular data. So close to the end, there is something that we need to give a few words, no? What happened to the so-called variants or histologic subtypes of bladder cancer? So here's the paper that can answer these to you. They observed in this very seminal paper, they observed a high molecular heterogeneity within each of these variants, which is a very important issue in terms of sampling, in terms of making a public, an open reflection of how can we approach these categories. To the end, just to show you this beautiful diagram for the paper of Robertson, what you see from immunohistochemistry on top, we can move to clinical information and to potential therapy. This could be very useful for our clinicians. So this is, as mentioned previously by Alessio Cimadamore, this is our proposal that we have recently published to try to push forward this implementation using immunohistochemistry in clinical practice. If you go to this image at the bottom, is using these integrative reports, these pathology reports then could be more rich, provide initial information that the oncologist, the urologist can use to decide further steps in clinical practice. So thank you very much.
Thank you, Antonio. I have a question for you. The next WHO classification of tumors of the urinary system and male genital organs will introduce a distinction among subtypes and variants. So the subtypes will be all the types of bladder neoplasms that we know with divergent differentiation, such as lymphoepithelioma light, nested, and so on. While the variants will be molecularly based according genetic alteration. And nowadays, probably only the subtypes will be introduced in the WHO classification. According to your judgment, it's now the time mature to consider the variants of bladder tumors?
I think this idea of using a single word like subtypes to identify several classes of things is of interest. I think it's not mature enough because the word subtypes cannot be used alone. It needs to have something else. It's a composite word. So, for instance, we can have molecular subtypes. This is a word that we use in practice frequently. Then we might have molecular variants, because our genomic variants used mainly in hereditary tumors and so on. And then we might have histologic subtypes. I think the idea is good. It is. I feel a little that the overall idea is a bit immature. It is still in discussion at the level of the WHO, and we will not have the final decision on that. So, but the overall idea is not bad. My opinion is that it's more than that. For instance, we have the urologists frequently, when they talk about variants, they include pure squamous cell carcinoma, pure adenocarcinoma, pure small cell carcinoma, and then histologic variants associated to urothelial carcinoma, like divergent, like micropapillary when this is associated. So it is a little confusing at this point, but the idea is good, and I hope they come up with a very good explanation on how to use this word in our practice.
Thanks, Antonio. There is another question. Are molecular subtypes a routine part of your biopsy report?
Yes, and I started a couple of years ago, in 2019 or late 18 maybe, I started to incorporate in my pathology report of muscle invasive, at that time, muscle invasive urothelial carcinomas. I have started to include some molecular data based on immunohistochemistry and based initially in two markers, CK20, which is a cytokeratin. For the urologists, maybe they are not familiar. Cytokeratin 20, which define very well the luminal subtypes, and CK5 or 6 is another cytokeratin that define well basal subtypes. And I start using this as a note in the report, just to provide the urologists and the oncologists with such information. And the urologists and the oncologists, they like it because they have a wider screen on the picture on the report. So, oh, this is basal, and then I can potentially use immunocheckpoint inhibitors. Then so at the level of the multidisciplinary meetings, this is very interesting, and our experience so far is quite positive. Now I use 4 markers. I have, why is that? Because, sometimes we have to go with the literature. And so I use 2 markers for luminal, which is GATA3 and CK20. And then I use CK56 and CK14 for basal carcinomas. And that's the way I use it. And I tell you, my experience is positive so far.
Thank you, Dr. Lopez Beltran. And now I will introduce, it's my pleasure to introduce Dr. Samira Maresma, urologist. She works in Cancer Center in Valencia. Clinical significance of a molecular classification.
For the next 10 minutes, my role will be to discuss the clinical significance of a molecular classification in bladder cancer. I have no disclosures for the current presentation. As Professor Lopez Beltran has previously mentioned, there are several existing classifiers of RNA expression-based molecular subtypes of urothelial carcinoma. Those include the UNC system, the MD Anderson classification system, the Lund classification system, 2 versions of TCGA, and the final consensus classifier that was recently published. Several groups have examined whether those systemic subgroups derive more clinical benefit from immunotherapy. What have we learned from currently published trials on IO? So basically from IMvigor210, that is a phase 2 trial with atezolizumab in metastatic urothelial non-cisplatin eligible patients, and primary endpoint in this case was overall response, which was actually 23%. In IMvigor210, when patients were subclassified by 4 strata according to the first version of TCGA superclassification, it showed the highest benefits in the luminal infiltrate subtype. And further analysis on the right on few pure neuroendocrine cases showed spectacular responses on that subgroup for immunotherapy. From Checkmate 275, which provided nivolumab on first-line metastatic cisplatin-ineligible patients, there were some significant differences, showing higher responses in the basal 1 subgroup. But there were also some significant percentage of partial responses seen in the luminal 2 groups. PURO1, which included patients with non-metastatic muscle-invasive bladder cancer receiving neoadjuvant pembro, we observed that luminal infiltrate had the highest rates of response to immunotherapy. Similarly, on the right, avelumab maintenance trial on patients having responded to chemotherapy, we see that basal subgroup is deriving the highest degree of benefit, with mixed benefits in the luminal subtypes. in order to investigate the ability of molecular subtypes to predict pathological downstaging and survival after neoadjuvant, a whole transcriptome profiling was performed on pre-neoadjuvant TURBT specimens from over 300 patients with muscle invasive. Overall survival according to subtypes was analyzed and compared with overall survival in 400 patients that had not received neoadjuvant. Luminal tumors in this case had the best overall survival with and without neoadjuvant chemo. Including low tumors were associated with poor overall survival irrespective of treatment regimen. Basal tumors showed the most improvement in overall survival with neoadjuvant compared with patients that only had surgery. But it's not only about basal versus luminal, but also about tumor microenvironment with lymphocytes, infiltrates, fibroblasts, natural killers, macrophages, and many other cells that are around it. So the role of tumor microenvironment in driving treatment responses has not been extensively studied in clinical practice. On this study, transcriptome profiling of over 130 patients with primary tumors, muscle invasive, treated with trimodal therapy, the authors aim to characterize the association between gene expression signatures of immuno and stromal infiltrates and the outcomes out of trimodal therapy. So tumors with higher expression of genes associated with T cell activation and interferon gamma had significantly improved disease-specific survival compared with tumors with lower signature scores. In contrast, among patients treated with radical cystectomy, no difference in outcomes based on immunosignatures were noted. So out of these results, they suggest that immunoactivated tumors derive a greater benefit from a trimodal approach probably. In fact, the presence of immunocells prior to treatment may provide a more favorable environment in which radiation can promote immunomediated cells. If we look at the stroma-rich subtype, for example, IMvigor210 has provided some answers. In IMvigor210, they also tested if responses to treatment were associated with CD8 positive T cell effector phenotype and to even a greater extent a higher neoantigen or tumor mutation burden. What they found was the lack of response was associated with a signature of TGF-beta signaling in fibroblasts. This occurred particularly in patients with tumors which showed the exclusion of CD8 positive T cells from the tumor parenchyma that were instead found in the fibroblast and collagen-rich peritumoral stroma, a common phenotype in those types of patients. Actually, that triggered some phase 1 trials that are ongoing to test this concept. Overall, a pattern starts to emerge. It seems like there is a relationship between those molecular subtypes that should be viewed more as a continuum or linear. On the left, we see the neuroendocrine tumors, which again are rare but exceptionally responsive. Moving to the right, we see basal tumors that seem to derive a higher degree of clinical benefit as well. And luminal infiltrate subtype and its equivalents are probably also somewhat responsive to immunotherapy, whereas the luminal papillary subtype is probably less responsive or sometimes not resistant. But still, further analyses are required to clarify these important targets. How does all this apply to real clinical practice? So if we look a little further on the luminal subtype, luminal papillary subtype on the left, that is associated with FGFR3 activity and low-grade papillary and good prognosis tumors. There are already some trials and have provided some targeted answers on this setting. For example, erdafitinib, that is an inhibitor of FGFR. It was demonstrated that it had some efficacy in a phase 2 trial that was conducted on over 100 patients with locally advanced or metastatic urothelial cancer harboring FGFR gene mutations or gene fusions. with the majority of them having progressed at least to one line of chemo. And as we see on the graph, at the median follow-up of approximately 1 year, the response rates were at 40%. Tumors had to be assessed either by initial onset of metastatic disease or at progression after initial lines. The major drawbacks of those treatments are the side effects, hyperphosphatemia and stomatitis. Those are very promising results, and we see other ongoing trials with other subtypes of FGFR inhibitors, as well as other ongoing trials in different settings, such as muscle invasive and non-muscle invasive. I will provide some answers in that setting. If we move a little bit forward and we look at the basal category that has also been mentioned, it represents approximately 35% of all samples, which is actually the most prevalent subtype. It is associated with genes including like EGFR, P53, or RB1. It's also characterized by stroma infiltration with fibroblasts, myofibroblasts, immunocells, and others. Afatinib dimolate is actually a drug that may turn off the function of EGF and HER2 receptors, and which actually may slow down the growth of cancer cells or cause some of the cells to die. Currently, some feasibility studies targeting the EGFR status have shown conflicting results in bladder, not in other tumors. And we have ongoing trials with this inhibition that are looking at some oncological outcomes already. Patients with genetic abnormalities such as mutations, amplifications, or translocations, we know that may benefit from treatments which target their tumors, particularly their genetic abnormality. Identifying those genetic abnormalities may help us treat better, actually. This is what MATCH screen trial aims to provide answers for in order to bring personalized treatment, and this is an ongoing trial. So take-home message for today on clinical applications of molecular subtypes of bladder cancer is that tentative profile for response to immunotherapy. It might be the infiltration of CD8 positive cells, the neuroendocrine subtype, high interferon gamma signaling, a low TGF pathway. Those combination trials that we have mentioned actually have improved our molecular knowledge on molecular subtypes. We have seen also that all molecular subtypes actually have a benefit in terms of maintenance of avelumab, that those molecular subtypes actually offer a good foundation for us to understand the molecular biology of urothelial carcinoma, and biomarkers that improve patient selection are urgently needed. Thank you very much.
Thank you, Maria. Thank you for the excellent presentation. There are few questions from the audience, but I think that a discussion needs for all the possibility that the new therapy allow to the urologists and to the oncologists. And so I now open discussion. I ask for example, the need for biomarkers that you have highlighted. For example, you how many times do you ask for PD-L1 expression to your pathologists? And if yes, and many times, it depends on the type of lesions or the clinical trial that you have the possibility to for it, including the patient.
So yeah, you're right. I mean, most of the time it depends on the clinical trial because this is what drives nowadays our treatments. Honestly, this is more on the oncology side because they are the ones running the trials. But in terms of PDL, probably you as a pathologist can tell me more that this is sometimes equivocal and it's hard to reproduce most of the time, and it requires some training.
Yeah, exactly. and many times it's difficult the standardization of the procedure. But I think that a rule of this biomarker could be interesting for also scientific purpose more than for a clinical evaluation. But what about the implication for lesions that are not invasive? There is a rule also for some clinical trials and immunotherapy in these lesions.
Yeah, so as I mentioned, for example, for the trimodal concept, it's not only about the basal or luminal, it's also about what's going on around the tumor. So probably you're talking about the patients that are very high risk, very aggressive T1, right? That they are probably closer to the T2 than what we think. And that will probably change in the next few years as a concept. And those patients will be moved more into more aggressive treatments earlier, right? Because they probably belong to that other subgroup.
So now my purpose is also to include in this discussion Professor Lopez and Professor Shimada-More, and which kind of experience you have about PD-L1 and the routinary assessment for in this setting of patients?
Experience. I mean, we are not oncologists, of course. Carme give us an overall picture, beautiful, on what is going on, and mainly what we see is that going on many important things, and as she mentioned already, there will be very, very soon, let's say, even movements or blocks of classic urology type tumors like high-grade T1, progressive, and so on, just to the oncology field, because the management will really be changed a lot. And one of the issues is that they change because of the immunotherapy. So that is something, and that is something important too, that using certain markers for molecular classification, we could potentially identify a number of those cases in an earlier stage. So, I mean, it's a beautiful landscape that I would say on the next few years for immunocheckpoints, molecular subtypes, and other inhibitors of fibrotic growth factors, and some others. So I have a positive feeling on that. And
I would say the summary is more about this work in progress, no?
Right. There is one beautiful paper published in recently, last year, I think, in European Urology. They put together information on more than 2,000 cases, and they made it beautiful. But it's quite complex to put it in a presentation of 10 minutes. You need half hour or more just for that paper. But there is one main thing: 20% of these T1 tumors, they have actually a molecular signature of a T2 tumor. So, and those could be, if not all, some of them or many of them probably will be identified by using a molecular subtyping by immunohistochemistry, CD analysis, TILS analysis, and so on. So maybe this is also an important issue. Maybe we need to integrate molecular subtypes with immuno information, with immunocell infiltrations, because can be very interesting. Maybe I talk too much.
Now, I agree with you, Antonio, but I'm a little bit skeptical about PD-L1 because we have experience on kidney and also in head and neck tumors. So the PD-L1 now is asked for everything. I don't know if the 1% cutoff is really useful to discriminate people that can respond to immunotherapy and patients that will not. And fortunately, our oncologist don't ask us for many PD-L1 on urothelial cancer, also because it's not required for immunotherapy. And it's a little bit challenging to evaluate the PD-L1, also consider the immune cell infiltration. And I read with great interest the paper on T1 published in European Urology, also because sometimes he proposed classification distinction in 5 subtypes, also based on the expression of MYC that we have in our panel of immunohistochemistry. So maybe it could be useful. And another thing is the expression of PD-L1 in carcinoma in situ, that in the neoadjuvant chemotherapy, immunotherapy proposed by Andrea Necchi in the trial, the pure one, seems that to have a significance, the expression of PD-L1 in carcinoma in situ. So maybe it could be something that we could use before, so not just neoadjuvant before the surgery, but just as a therapy like BCG, like the same concept of BCG.
That's an excellent point.
Useful in that context. We should investigate, of course. We don't have enough data to classify tumor in basal and lumina just based maybe on the 2 immunohistochemical marker. Is of course is helpful, but you cannot, my opinion, you cannot simplify all the RNA data set or RNA extraction molecular data to just one marker. So it's good for us, but maybe there should be more. Also because in the classification of glioma, we already from 5 years from now, the glioma is being classified also according to the molecular IDH mutated or not. So we should do something similar in the bladder.
Yep.
So we have more or less 5-10 minutes before the end of this session. I asked for Professor Rupré is here.
Yes, I'm here. Good evening. Thank you.
Hi, hello.
For giving me the opportunity. Can I share my slide?
Yep.
Yeah, perfect. Thank you. I was asked to give my point of view about the question whether or not in bladder cancer, the morphological classification will become obsolete. I think I'm not so sure that I will be in a situation to answer tonight, but anyway, I will give you some insight from my side. So in urothelial cancer, there is a lot going on, obviously, in the pipeline, and from the clinical perspective, even non-muscle invasive bladder cancer, muscle invasive bladder cancer, upper tract tumor, there are, of course, discrepancies, disparities, but also a common problem, and all the clinicians are working into that direction. So the good news of the 5th edition of the WHO 2021 is probably coming from the fact that the histological characteristics remains so far the gold standard for the classification, as I understand, and diagnosis of urothelial tract tumor. So this is the message I would like to emphasize. The classification of the system in urothelial tumor is quite, I would say, exhaustive. You all know it better than I do, because you are well, I would say, a non-expert in the field. But carcinoma in situ is particularly complex from the clinical perspective in terms of diagnosis, also prognostic and therapeutic management. Grading invasive urothelial cancer can be challenging. Low-grade invasive UC lacking significant nuclear atypia can be rare. Required to grade every invasive UC. There is no clear recommendation on how to proceed and how to do that. You mentioned also previously the histological variants and subtypes, and those with divergent differentiation. They are all considered so far that high-grade tumor. Is that fair enough? Is that sufficient? I don't know. Tumor heterogeneity. The heterogeneity appears in grade, 1/3 of non-invasive papillary urothelial carcinoma. In the 5th edition, it appears that papillary tumor has high grade, more or less over than 5%. So a pragmatic approach would say that we need help or unmet need in a more consistent grading of tumor with grade heterogeneity. to help us in the clinical management of these people. What about the T1 substaging? There is a consensus, an overall consensus about the prognostic value of assessing the extent of the lamina propria. Do we need higher subcategories to correlate with recurrence and stage progression? This is a fact coming from the evidence that we have. Several approaches have been proposed for PT1 subcategorization. Anyway, I don't see on the field this coming from bench to bedside. Prospective studies carrying head-to-head comparisons of various methods should be probably requested, and the awareness about the substaging is probably useful, but it may complicate at the end of the day the staging of at the sites, and it depends where you practice and where you recruit the patient. And we have to admit that contingent upon the fact that we are in a high volume center with, I would say, dedicated surgeons, clinicians, pathologists, radiologists to the disease, it makes it, I would say, more easier. For the molecular perspective, there are much data coming on, comprehensive molecular classification. The problem, I would say, are the cutoff. There is probably a consensus, but there was a communication at the AU 21, and I will come back to that, criticizing the molecular classification from the clinical perspective for the urologist. For the molecular landscape, the mutational landscape, transcriptomic, proteomic signatures, it means a lot in terms of basic research, but more data are needed. Currently not reached the threshold for consistent application in routine pathology practice of patient management. And I didn't discuss also the cost issue that could come along with the use in daily practice of such studies. There was these two consensus papers from the GUPS published extremely recently. A big work, people coming together, pathologists, clinicians, and so on. So it's, I believe, something that it is interesting. And I would like to come back to this communication from Merseburger at the AU 21, coming up along with the criticism of the molecular subtypes in muscle-invasive bladder cancer. I mentioned all the research and the money and the energy which was involved to identify the luminal, the basal, and to correlate with the clinical outcomes. The problem is that the molecular subtypes strongly correlated with tumor grade, could not predict overall survival or recurrence-free survival, were a bit suboptimal when it comes to OS and RFS. And in contrast, the good old-fashioned pathological parameters, LVI, predicted both overall survival and RFS. So I'm just not, I do not want to step back and to go back to the future, but just saying that so far, I'm not so sure that it is ready for prime time. There was this tweet from Juan Palu saying that excellent talk by Dr. Merseburger, molecular subtyping not ready yet for clinical use. It was in July, we are in September, so I'm not so sure that it is ready for prime time. In between, tumor heterogeneity influences molecular subtyping in bladder cancer. Clinical parameters outperform molecular subtypes in predicting clinical outcome and treatment response. This paper also been released at the bottom of the slide in UROwebinar 2020. So not criticizing, just being pragmatic on a conclusion perspective of that, I would like to say that molecular will never be able to replace surgical pathology to date. So far, surgical pathology only can tell you grade, stage, LVI, CIS, subtypes, it's cheap, and the cost issue cannot be neglected. It's quick, and molecular so far is coming on top of that, but it's not replacing. This is what I would like to send. This is my view. Thank you.
We as pathologists are very grateful for your assessment of the rule of morphology, and there are now only few questions. I think that you are could answer about this question. Can you please comment on discordance on metastasis and the efficacy of agents in this setting of patients with an heterogeneity of the metastasis respect than the primitive tumor?
You mean at the metastatic stage?
Yeah.
Yeah, surely the problem is when it comes to the metastatic stage, most of the time the people are the past medical history with the natural evolution, I would say, of the tumor. And my point is that in the vast majority of cases, you are going to rely on the bladder specimen or on the TURBT, which was done earlier on, and it's not always on the metastasis itself. So it means that there is probably an heterogeneity in urothelial carcinoma, and there is a mutation and a variation during the natural history of the disease. So my point is that it is quite difficult to be sure when it comes to metastasis patient that you have a contemporary biopsy or assessment at the moment of the metastasis. And in addition, there are two categories of patients with metastasis, with or without their bladder, because they are metastasis from the beginning, or they had to face the multiple steps of the evolution of the natural history of the disease, and the bladder was taken out, which makes it a bit different from my point of view. So it's, I would say, complicated.
And I think that also the other question is for you. Bladder cancer subtypes are suitable to use in assessing the treatment strategies to address the strategy.
Yeah, probably depends. It's more, we learned from you guys that the pure urothelial carcinoma is dream, does not really exist. So at the end of the day, so we have histological variant. It depends on the proportion, the type of the variant, and we could decide to move straight forward for cystectomy if there is a particular variant, micropapillary, very aggressive, for instance, and it depends on the majority of the specimen. But we have to be cautious because usually we make an assessment on the TURBT specimen. It has nothing to do when you compare the TURBT specimen and the cystectomy specimen. So if you decide to choose for a neoadjuvant chemo based on the TURBT, there were several papers demonstrating that the fact that you could depict histological variant on the TURBT specimen is not sufficient enough to avoid doing neoadjuvant chemotherapy. So probably it's going to be to influence. There are new treatments in the pipeline based not on the histological assessment, but the presence, for instance, of mutation, FGFR mutation, and you go for erdafitinib or so on. But I would say it's too early to say. At the moment, I mean, most of the decisions are based on clinical and so-called regular pathological criteria.
Thanks. The last one is, there are other two. What are the situations where you require molecular classification? I think that the meaning is when you need the molecular classification, the molecular status of the
in daily practice, outside trial, nowhere. So the thing is whether or not you're in an academic center, and this is my case, and so we are trying to do a lot of research. I'm running as a PI a phase 3 trial in non-muscle invasive bladder cancer. So we have ancillary studies, we are doing basic research, and so on and so on. So there is always this gap between the communication, the basic research we have at the scientific events, the paper on PubMed and so on, and the reality of the practice. So it's not ready for prime time. I don't know. It's my vision. Maybe you are using it on a daily basis. But outside clinical trial, I would say that it is premature to say we should do that.
The last one really now is PD-L1 status before and after BCG therapy. If there are any known study for this comparison, so PD-L1 in BCG therapy have any importance for the oncologist? That's the one. PD-L1 assessment in patients that are treated with therapy with calmergaren bacillus.
As far as I know, there aren't, but I can suggest to read the paper from Pierre Conti, who studied the PD-L1 expression in BCG responders and non-responders. That's the only one paper that I know on PD-L1 in BCG.
So now we are at the ending of the session. I thank all the audience. Only 4 participants, 4 out of 200 have lived before this meeting. I thank all the co-chair, Professor Rupré, and all the speakers. And bye-bye for the next possibility to share with the group of oncologists.
Thank you.
Bye-bye.
Hi, good evening.
Bye.
Bye-bye.